Hi, this is Tesha Monteith with the Neurology podcast. Welcome to our 2023 November headache series. We're doing it again this year because it was such a success last year. I promise you, we have some exciting audio programming in store. We're bringing on the leading experts to discuss the most relevant and important headache highlights on a full range of conditions. You don't want to miss this.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
This is Tesha Monteith with the Neurology podcast, back with our November series in headache. This session will focus on the most important highlights of the International Headache Congress, which just happened in September in Seoul, South Korea. It was the first time in Seoul and the second time the Congress was held in Asia since the 2005 meeting in Japan. The meeting was appropriately themed Rising Sun Over Headaches, towards a global access to headache science, technology, and healing, and was a great success. It was awesome to see so many people from all over the world, as well as great science. This could not be possible without the efforts of the Congress Scientific Program Committee co-chairs. With me to discuss is Gianluca Coppola from Sapienza University of Rome, Italy, Hayrunnisa Bolay from Gazi University in Turkey, and Casey Brennan from the University of Utah here in the US. I just want to start off with you telling us, what was the process like? You're at different time zones and you've selected some of the best science that I've seen.
For me personally, at least, this was just a really beautiful example of a global effort. We spanned, just the three of us, almost 2/3 of the time zones of the world. And then when we met as a full group, we really literally spanned the 24-hour day-night cycle. That was a cool experience in itself, but it also represented that this really was a global effort.
It was a global combination of minds almost every week for 2 years. It was, I think, a huge effort in order to combine our times, our work with the trying to put everything on setup as early as we can.
We were a good team and everybody was putting their, intellectual capacity. We were seeking for new opportunities to include mainly the all continents, all people, but it has to be with high scientific value. And we also spend a lot of time to invite particularly female researchers or young people in the field. So my time was always late nights or late afternoon time, but it was very difficult for Casey, like 6 a.m. or something very early in the morning. And Gianluca was at the hospital, but that was good. Yeah.
So tell me a little bit about the submissions themselves.
Well, we had over 600 submissions total, and the science quality was uniformly incredibly high. I think because this is a global conference, we tend to get people's best work. Like Hayrunnisa mentioned, we also really made an effort to include work from every continent that met scientific standards and work from historically underrepresented groups in our field, right? Whether they be geographic groups, whether they be women in science, whether they be other underrepresented groups, there was a real effort to include this highest scientific standards and also really making this global.
I think we can say that we were proud to receive a lot of submission from young scientists who scored the highest when we have to score each abstract, So very proud to receive this huge amount of submission from young scientists.
So what scientific sessions did you find most interesting?
I really enjoyed the session on biomarkers and also the plenary session about morphofunctional activity of the migraine brain. They tried to explain us how electrophysiology and neuroimaging usually increase our knowledge about migraine pathophysiology.
Based on some of the science that was presented, what areas do you think are most promising in terms of advances in headache medicine, be it migraine or other headache disorders?
There are a huge improvement in neuroimaging techniques, especially those analyzing some functional aspect of the brain. They can combine with electrophysiology as well as biological samples in order to improve and personalize headache medicine in general. And there are many new aspects about also cluster headache, how they can improve in the understanding of their pathophysiological aspects, especially chronic cluster headache. I will say the role played by the midbrain, for instance, or the dopamine and ventral tegmentum. So we improved in many aspects of the headache field.
I think all of us have an intuition, neurologists or headache specialists, that the cerebellum must be involved in migraine. It's the place where there's the highest burden of white matter lesions on MRI. Many migraineurs have sort of form-fruste cerebellar symptoms. They talk about being discoordinated, either episodically or chronically. And there's work from a new investigator in migraine, Levi Sowers at the VA in Iowa, basically showing us that there is an anatomical basis with rigorous scientific work for this cerebellar phenotype in migraine. What they did was stimulate, using primarily optogenetics, the median cerebellar nucleus, and just stimulating that one region with genetic specificity, they elicited migraine-like symptoms, photophobia, and others. So this is, to me, one of the exciting things about the conference is we have a lot of clinical intuition that's probably right, but that hasn't been validated. And instantiating this intuition in scientific models where we can build forward from them and generate new treatments, that's what's really cool to me.
We now are in the position that we can translate clinical symptoms in specific area involvement. So this is, I think, what we are dealing nowadays, and this is also for the future.
Hayrunnisa, what would you say was most promising to you? And then I want to ask all of you about what areas did we not see enough of?
There was also, I think, very important, maybe new concept. This is the gut-brain axis. And you need the irritable bowel syndrome, which is a functional gastrointestinal disorder. And it is related to the leaky gut, which is increased intestinal permeability and probably some destruction of the intestinal barrier function. And there was at least 2 studies showing that in the clinical one, the frequency of irritable bowel syndrome is increased in medication overuse headache. And that makes sense because in those group, we are dealing with the chronicity of the migraine, and the food and, all this treatment is really difficult and challenging. And thinking about considering the, importance of leaky gut, I think that makes sense, or that may be important for their management on their, treatment. And also, similarly, group showed in a female rodent model that non-steroidal anti-inflammatory drug use also cause lipopolysaccharide leak into the bloodstream. That was good addition to the clinical study, and they were also showing us that we need to focus more on the diets and food ingredients, and probably the stress and all the other factors which cause the leaky gut. That's also a new achievement, I guess.
And so what type of research would be nice to see more of?
We don't have a deep understanding of how migraine or any primary headache is developed. We don't really fully understand. And I would like to see trials or preclinical studies where they fed by clinicians and also the good scientists to solve as a whole this problem. Everybody is looking for a little part or very focused one part, but we don't have any holistic approach or holistic understanding. And that is one of the problems, that there is a huge gap translating preclinical studies to the bedside or in the headache field, unfortunately. And that brings us to another issue that I believe we need a new perspective to understand better, that everything is just repeating itself in the pathophysiology, in the treatments, but something, we need a paradigm change to go to this level, I guess.
I know Casey's excited about that because he talks a lot about paradigm changes. So go ahead, Casey.
I think there has in the past in our field been this rather to use the words of now head of NINDS, primitive thinking about our disease state, right? This is a network disease. It's incredibly complex. It's individualized to the human that suffers from it because these are their brain networks that have grooved into some sort of dysfunctional pathway. And in the midst of this disease complexity, we've had these almost Manichaean debates about migraine is central, migraine is peripheral. It's a part of the central nervous system, part of the peripheral. Utterly specious debates, right? The disease involves an integrated nervous system that consists of central and peripheral parts. Another one of these Manichaean black and white debates is about migraine is neural, migraine is vascular. No, it's neurovascular. Right? The primary afferents that are likely the most important for this disease live on blood vessels. And so there are these sort of pendulum swings. And I think this was visible in the scientific content of our meeting. And I think there was good data to support this more integrative thinking that Hayrunnisa mentions about our disease. It really is sort of a dialectic, right? You get these sort of point, counterpoint, but we got a little stuck for a while with these debates. And I think we're moving past that. I do have some more hope. I can offer some specifics about data that says, the disease is neurovascular or that it's both central and peripheral if we want that.
Yeah, go ahead. My next question is about the overall state of migraine research, and you're just diving right into that last question. But go ahead and give us that specific data.
The most interesting integrative data for me, saying that in particular migraine is a neurovascular disorder, right? It's not neural, it's not vascular, it's both, is data from the group in Denmark showing that eNOS, not nNOS, so endothelial nitric oxide synthase, not neural nitric oxide synthase, was what was activated by one of the most potent activators of headache, levchromocalin, ATP-sensitive potassium channel opener. So the significance of this is that it is localizing release of a migraine-inducing substance to the vasculature rather than neural structures. And then Masuda Shina's group, also in Denmark, a separate group, when you use another category of potent inducer of migraine, ATP-sensitive potassium channel openers, and you use a version of these potassium channel openers that does not act on blood vessels, you do not induce migraine attacks. So there's a requirement for at least this class of drug to act on the vasculature to induce migraine attacks. There have been a lot of statements to the effect that the vascular phenotypes of migraine are bystander effects, are not part of the causal mechanism of the initiation of the migraine attack. The vascular phenotypes of migraine are an epiphenomenon and not mechanistically or causally involved in the generation of a migraine attack. This data is showing that a essentially non-vascular K-ATP opener does not induce migraine attacks is evidence against that. It's evidence that the vascular phenotypes of migraine likely are necessary in the generation of the migraine attack. But of course, again, we don't have to swing all the way that this disease is only vascular. Of course it's not. We require the nerves on these blood vessels to be activated to generate an attack.
Yeah, we just acknowledge the role of vascular structures, not we are swinging to the vasculature again.
Exactly. Like no more pendulum swinging. Let's
Yeah.
Yeah, I was looking to the list of presentation of the Congress, and I must say that considering what Casey and Hayrunnisa have told us, we should move from considering migraine as a single pathology as a syndrome, I must say. You have a huge involvement of the immune system, of the inflammation, neuroinflammation, but also peripheral inflammation. Migraine is highly comorbid with many central and systemic disorders, cardiovascular, cerebrovascular, but also multiple sclerosis, epilepsy, gut disorders. So a lot of comorbidities and neurovascular involvement. Coming back to the initial evidence of the brainstem involvement in migraine, the spot in the neuroimaging, we know that brainstem monoaminergic system regulates the neurovascular coupling. So back to the basics. Why we have the involvement of the brainstem, which is the role of the trigeminal system, just the signaling of headache, of pain, probably not just pain. Why we have the involvement of the hypothalamus? Why just before the beginning of attack? Why not during the interictal phase, when probably something is going up to the tipping point of a migraine attack? We have such a huge amount of unanswered questions. Even in 2023 with monoclonal antibodies, for instance, why we have such an involvement of the peripheral system, neurovascular system, CGRP and PACAP, but we see patients not responding to monoclonal antibodies. Not to one, but even to 2 or 3 monoclonal antibodies, different monoclonal antibodies, not responding to Japans. So we have much more to learn in order to give an answer to our patients.
Well, I think that was a great way to wrap up this session. I really appreciate all of you being here because we got a lot out of this discussion, actually. It always surprises me how much when, great minds get together. So thank you so much. And be sure to check out the series going on this month.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.